I want to welcome everyone to our 2022 Know All Your Treatment Options Disease Education Meeting and Event, as well as a very inspirational event that we have happening today as well, which is our 2022 National Hope Award Campaign and Initiative recipient. So welcome everybody. And it was really nice getting to chit chat with some of you earlier today. And I really appreciate you taking the time to join us. I promise you that you will meet brain tumor specialists and you will hear about their research, their treatments, advanced treatments, and clinical trials that you most likely are not aware of. And that is our goal today, to bring you a program where you learn about a lot of different treatment options, and you also are able to make connections with healthcare providers in this space. So thank you for joining us. I want to take a moment to acknowledge all of the many sponsors that it takes to put on an event like this. We appreciate our relationship with Novacure. Novacure is a longtime sponsor of our National Brain Tumor Hope Award, and Gamma Tile is sponsoring that event as well. And we really appreciate it. It helps us in so many ways and helps us create large awareness and outreach. I want to also thank Cure Magazine. We have a relationship with them and they help us an amazing amount with disease education, awareness, and outreach. Also, I would like to thank WIM Social, Great Purpose Productions, Conscious Communications, and we also have disease education support for today's event coming through the grant side from Novacure, as well as Genentech, who supports many of our small group meetings. And I also want to thank our individual donors who also help us continue the mission and the work of the In Brain Cancer Initiative. Thank you everyone for joining us today. Today is really exciting. We are going to learn a lot. We're going to be inspired. We're going to share. And really, it's about the brain tumor community working together in order to create access to advanced treatment options and to clinical trials and to specialists, and in some cases, also to standard of care. So today we have a packed agenda, because that's how I like to develop these programs. We will be soon meeting some of our this year's National Award finalists, as well as meeting our recipient this year. We will then hear from Dr. Nader Sanai. He is with the Barrows Neurological Institute and specifically with the Ivy Brain Tumor Center. We will then hear from Dr. Chautka. He is with St. Al's Neuroscience Institute, which is actually located in Boise, Idaho. And he's going to be talking to us today about a clinical trial called the Rhodes Study. And he's going to educate us today about gamma tile therapy. And then we're going to meet a patient ambassador and his wife, who's also a caregiver ambassador. And so we're going to get to meet Dennis and Yvonne, and they're going to share their GBM story and what they're doing for the brain tumor community. That will be followed up by a presentation by Dr. Leo Lusgarden, and he is with the global medical team, Novacure, and he's going to be talking to us today to help us understand tumor treating fields. We will then learn, because it is actually the In Brain Cancer Initiative's 20th anniversary this year, we have been developing, and we have now done a very soft launch on our gift to all of you, which is the In Brain Cancer Initiative app. It's a mobile app, and so you'll be able to get information now quickly through our EBCI application. So Sean Drennan with our organization will be going over our app today and helping you download it if you would like. And then we're going to talk about ways to support EBCI's mission and work and programs and our capacity, because we desire to help more and more people. At the very end, we're going to continue the conversation like we had earlier today, just very informal. and we would like you to share what's on your mind. Are there different ways we can help? As well as if you have any other ideas on how to make this event better in the future, we'd really like to hear from you too. So with that, let's get going. I want to remind everyone about different ways to support the work of the End Brain Cancer Initiative. So yes, we're in the world of text. You can text EBCI. Text us, EBCI, to 44321 to make a donation to support our work and our mission. Of course, you can go to our website, endbraincancer.org, and make a donation. Or you can even literally scan our QR code that we have in order to make a donation to support the work of the End Brain Cancer Initiative. And because we have several companies joining us today, I don't want you to forget how important corporate sponsorship is to our organization, as well as disease education. And there's different ways to work with us to create these kinds of programs for your company so that we can create larger access for patients to, again, treatment options, advanced treatments, and to clinical trials. And if you are interested, if you're a company and you're interested in creating some kind of a corporate partnership, I ask that you contact Shawn, SHAWN, at endbraincancer.org. So we are moving quickly because we have a lot of wonderful information to bring you this year about our National Hope Award. With that, I'd like to introduce our marketing director, Susan Kellner, who's going to speak a little bit about our Hope Award and, as a recipient, what this award meant to her.
Guess I should unmute before I talk.
I hear you.
Hi again. This is Susan Kellner. I've been working with End Brain Cancer for close to 10 years now. I actually came to them as a patient, and I was so overwhelmed with the help they provided and the doctor they got me into that I was willing to do anything and everything to help them. And now it's been almost 10 years and I'm still here and I love it. I was a recipient of the Hope Award back in 2013, I think, maybe 2014. The Hope Award actually means a lot to me, not just because I was a recipient at one time, but I get the pleasure of getting to know all of these people who have been nominated and hearing their stories and putting together videos. And I feel like I'm one of the luckiest people to be able to really understand the difference that these patients and caregivers are making in the world of the brain tumor community. So it's a true honor for us. This is a big deal to the End Brain Cancer Initiative. It is every year. It is so hard to decide on who gets this award because there's so many amazing people out there. And our huge push is really just being able to get people's stories out there, because every story matters and every story can have an impact or an influence on somebody else's life, especially the newly diagnosed. So we're very honored to talk about some of our nominees and this year's winner.
Thank you, Susan. I appreciate that. And again, once you're a Hope Award winner, you're always a winner. Thanks, Susan, for all that you do for the End Brain Cancer Initiative and the brain tumor community. So again, this kind of Hope Award, it's an initiative, it's a campaign, right? And we like to hear from people who are living with their brain tumor. And while they're living with their brain tumor, we like to hear from them how they are inspiring others, how they are seeking out additional treatment options, right? How they're seeking out working with specialists in this field, and literally how they're telling their story, how they're reaching out to others. And so this particular endeavor is a campaign that goes on for many, many, many months every single year. And again, I want to thank our supporters for supporting this effort. It's truly important. We do enjoy engaging with the brain tumor community and learning from you. So thank you so much. I want to thank a longtime supporter, Novacure, for this particular initiative. I also want to thank Gamma Tile Therapy for supporting this initiative this year. And again, we want to thank Core Cryo, Great Purpose Productions, WIM Social, and Conscious Communications, because honestly, it takes a village to do this. And this team here puts together an amazing amount of effort on this particular initiative every year, and we can't do it without you. So thank you so very, very much. Okay, so Susan was talking about how we receive a lot of nominations every year, and it truly is very difficult to figure out who is going to be our recipient for the year. And so we have a couple of finalists that I want to quickly talk about, and then we will make the announcement of who our 2022 National Hope Award recipient is this year. So having said that, I'd like you to first meet Daniel Bear. He was diagnosed when he was 5 years old, and today he's 20 years old. And it's really interesting. His entire neuro-oncology team nominated him for this award this year. And his story is very, very inspiring. You can see in this photo that he is holding a Nike Air Max 95, which he helped design with Nike. And he designed this particular shoe so that he wanted to bring awareness to vision impairment. And he sure has. He's a remarkable young man, and we are honored to be able to get to know him a little more. And what we want to do, just so you know, our recipients and our finalists, we're going to be creating disease education videos about them as well in order to get their story out. I had the pleasure of interviewing the people who nominated Daniel I think it was last week. And it was just a privilege to learn more about him. So I want you to wait for that disease educational video. And they express hope is the ability to embrace the possibility of a positive outcome. And moving on, one of our other finalists is Fran Noonan. Fran is joining us today along with her daughter, Lauren. And those of you who were with us earlier, as we were just kind of getting onto our Zoom meeting, we got to meet Fran just a little bit then, and also Lauren. But Fran is a finalist as well. And she actually was nominated by Dr. Andrew Sloan, who is her surgical neuro-oncologist. And the way that he explained hope is the ability to look at your diagnosis head on and continue fighting. And one of the most important things that Dr. Sloan said to me is he said, malignant brain tumors are a major clinical challenge in modern medicine. And we know that, right? The last therapeutic drug, the GBM, which was Timodor, was approved nearly 2 decades ago. And he goes on to say, more patients die of brain metastases every year than any single cancer, such as breast, lung, colon, etc., combined. We must make this a priority. And what he's talking about is he's talking about brain tumors. We must make brain tumors a priority. So Fran is incredibly instrumental in her inspiration. And we actually will learn a little more about Fran, a little later from her daughter. And so hang tight. Another person I'd like to bring your attention to is Shannon. So Shannon actually was nominated last year as well for our National Hope Award. She was nominated again this year. And Shannon is joining us today as well. And she says, her mom says, related to hope, this is what her mom says. Hope looks like your daughter when you see how she is so strong and courageous, even when you are afraid and not as strong. She shows you strong faith and helps your faith to become even stronger. Hope is also hearing and learning that there is new medical technology and advancements that are being made in helping with the treatment of brain cancer patients. So Shannon, thank you so much for your embodiment of hope and sharing your story with all of us many, many, many times. And I actually am going to contact you a little bit later because I have this really great project coming up in a couple of weeks that I want to talk to you about. So hang on, more on that later. Okay, so moving on. I would love to hear from you guys. You know, feel free to email us and let us know what hope means to you. But we think hope is the ability to embrace the possibility of a positive outcome. And we'd love to hear what that means from you. So without further ado, I would like to bring back Susan to talk a little more about last year's recipient of our Hope Award, Bruce Rinker.
Yes, so some of you may know or have heard of Bruce. He is a scientist, he was an ecologist, he's a teacher, total brainiac, but very funny as well. I really enjoyed getting to know him last year. It was an amazing, amazing experience hearing his story. He's written a book on, it's called A Pearl in the Brain. I think the subtitle was the Cancer Journey of a Scientist in His Research for the Seed of the Soul. So it's basically a story he wrote about his path of being diagnosed. He was diagnosed with stage 4 GBM back in 2016, and he is going strong today. He is a beacon of hope for those around him, and we were so honored to have met him and given the honor of presenting last year's award to him.
Thank you, Susan.
Mm-hmm.
I think we need to move on, and I think it's time right now to announce our winner, right, for this year for our Hope Award. Are we ready to do that?
Indeed.
Okay, awesome. So we are going to announce Fran Noonan as our 2022 Hope Award winner. Congratulations, Fran. Where are you? Oh, there you are. I see you.
Oh my gosh. That's awesome.
Well, you were awesome, by the way.
You deserve it.
Well, thank you so much. This is such a great program.
Thank you.
And the big word is hope, of course, and being able to present that. So,
Absolutely. Absolutely. And you do. And so is it okay if we play a video that we created to help everyone understand how you convey hope and what you're doing to help the GBM brain tumor community?
Sure. Yeah.
Okay, we'll join you in just a minute. So you were doing your standard of care after your surgery, right?
Yes.
And so
my daughter Lauren found this Facebook group on it's called GBM Survivors to Thrivers, and
oh yes,
and
that's wonderful.
Yes, so she posted in there asking a question about has anyone ever had a recurrence in their corpus callosum, and this woman answered, and she was a patient of Dr. Sloan. The night before I was supposed to have the gamma knife, Dr. Sloan calls, and after he talked to me, he says, "You're a perfect candidate." And I said, "Well, I'm getting gamma surgery tomorrow." He goes, "Oh no, you're not. You're coming to Cleveland." So I believe I was the first patient to have the infusion first before the surgery.
Fran was the first person to get it up front. So she was not the first person on the trial, but she was the first person in that third arm that was potentially higher risk.
I was able to get 65% of the tumor through the LIT procedure, which was awesome because I had hardly any healing time at all.
She is about a year and a half out, a little over a year and a half out, and she's doing great. In fact, there's no evidence of tumor in her brain. So we're really pleased.
I feel great. I feel great. No cancer. They're saying that I'm remission, and yeah, they can't say I'm cured because there's no cure for glio. Hopefully, this will empower the medical board to allow this treatment because it works. It works for me, and and I'm living proof that is like the light at the end of the tunnel is, and I get it. I get emotional about it. Don't ever, give up. Always look for more ways to fight this, and you'll survive. You'll be able to survive well.
Because Fran's my patient. I'm going to do the best thing for Fran, regardless of whether she's on my trial or not. I think she's terrific.
So he is my hope. He's the vision of hope. He knows what he's doing. He's excellent at it. And he believed in me when no one else did. They don't know me. That's all I would say to those doctors. You don't know who I am and how hard I'm going to fight for this. Because these two little kids here, that's what I'm fighting for, and my family. That's what I say hope is. Never stop fighting, never give up, and if you get a second opinion, you're not happy, get a third, fourth, and fifth.
Because she's really gotten the word out there that even when people tell you it's come back, and even when people tell you it's hopeless, it's always a good idea to get at least a second opinion.
Yeah, we share it on the Facebook page, what I went through, and they're always asking me, what did you take? What did you do different? And I said, the best thing I did was to find Dr. Sloan. I
would say she's courageous, uncommonly generous, and a wonderful ambassador for brain tumor research.
Wow. Oh, that's so, yay.
I'm not crying, you're crying.
Fran, you are amazing. I just want to thank you so much for your inspirational story, for sharing it, but also you're so busy helping other people who are diagnosed with brain cancer as well. So thank you so very, very much. You embody the National Hope Award. And thank you so much. I want to put up a slide that actually shows, there it is. It shows Dr. Andrew Sloan, who nominated you for this award, but it also shows some of your family and your caregivers, Dustin and Lauren Noonan Brown. Lauren is with you right now, your daughter, correct?
Sister is also on this. She's in this. She's tuning in as well.
Oh, good. Oh gosh. Okay, that's awesome. So Fran, we have a few moments. If you would like to tell us your concise story and your messaging in your own words, please feel free.
I ramble a lot, so
no, you know what? Lauren's going to keep you on track, and so am I. And I want to ask you, can you scoot a little closer to Lauren so we can see you? There you are.
Okay, here I am.
Remember, we're in an RV. We're on the littlest bench.
They're on the road again. Okay, let's hear from Fran.
I think the biggest thing, like it said in the video, was don't give up, always stay positive. There's people out there just like you, and everybody's working so hard to try and find a cure for this, or at least a way to get through it. And that's the hope, is that you'll find your someone. My someone was Dr. Sloan and his team, and I'm forever grateful for that. And my kids, my daughters, Carrie and Lauren, I mean, if they didn't do the research and, I mean, when they heard what the diagnosis was, it was a death sentence. And they're like me, they fight. My one daughter just found everything out she could about glioblastoma, and through the internet and research and else, I mean, there are news, and I'm hoping that with your guidance, that they'll be able to reach out and find hope, you know, because it's there. It's, I mean, I'm thriving. So
Fran, you are a
But
beautiful.
I have my,
Go ahead.
thank you, my family. What's that?
She was talking good.
Oh, I said, my family is the absolute pedestal to where I'm at. If they didn't push me and encourage me, that, you know, I wouldn't be here.
But you are. And
I am.
that's exactly, thank you so much, because, you know, we know this disease is a tough one, right? But the fact is, you have to keep finding healthcare providers who can continue to offer you more tools in your toolbox, right? So
Exactly.
treatments, advanced treatments, clinical trials, diagnostics, devices, the whole gamut,
Yes.
right? Those are
Exactly.
tools in your toolbox. And
Yes.
that is what brain cancer patients need to have access to. So thank you for sharing your story, Fran, and congratulations.
Thank you so much for the award. I appreciate it.
Oh, you're
It's-
welcome. So your award will actually, I don't know where you're at, but your award will actually be coming to you in the mail. So just so you
Hold
know
on,
that.
someone's. Okay, what did you say? I'm sorry, Delanne. Somebody screen shared and I.
Oh, that's okay. Fran's award will be coming to her in the mail. It's from the In Brain Cancer Initiative. It's also from NovaCure. It's also from Gamma Tile. There you are. So thank you so much. Look forward to sending that to you. Lauren, I have about 1 minute. Is there anything that you would like to share?
I would just like to say, you know, make sure your advocates, that your caregivers, and well, first of all, I'm so proud of my mom. She is such an inspiration to everybody. But as caregivers, please be those advocates to help your GBM patient through that, because it's so important. And like my mom said, my sister was instrumental in finding out what we could about everything, and, you know, just follow their lead. And if they want to keep fighting, you say, all right, let's fight just as hard. So, and I did see that someone asked the question, she did have the lit procedure with pembrolizumab, which is Keytruda. So
on the recurrence.
on the recurrence. So that is what Dr. Sloan performed, was lit, which is laser interstitial thermal therapy.
Exactly. Also, just to let you know, all of our presenters and speakers today, including Dr. Sloan, who spoke to us via video, we will be able to share their contact information with you, with everyone who's registered here, so that if you do want more information on any of the treatment options or trials or advanced treatments that you hear about today, you'll be able to reach out directly for that information. Okay.
Can I say one more thing? I know it'll take 2 seconds, but one thing that
Quickly.
we've learned through this is that if one institution says that there's no other options, keep looking for another institution. It doesn't make them any less important, but there is someone out there that could possibly do it.
You are so right on. Thank you, Lauren, for adding that very, very incredible bit of information, because that's the truth. That is
Thank you, guys.
okay.
I don't
So
know if my other daughters.
we are going to wrap up, and thank you so much, and congratulations again, Fran. Thank you.
Thank you so much.
Oh,
And God bless you all, everyone fighting this. We're all in it together.
oh, it's a pleasure to be here with you and serving the brain tumor community for the last 20 years. It's an amazing honor. So thank you. Now we'd like to turn our programming over to disease education. And I believe we have joining us next, we have Dr. Nader Sanai. And he's going to be talking to us about phase 0 clinical trials, current recruiting clinical trials where he practices. I would like to read a little bit about Dr. Sanai if I could. And I'm also extremely excited and honored to announce that Dr. Sanai has joined our medical advisory group. So I'm really thrilled. Thank you so much, Dr. Sanai. We all look forward to working with you closer, all of us from the In Brain Cancer Initiative. So Dr. Sanai's bio is this. Nader Sanai, MD, is the J.N. Harbor Professor of Neurological Surgery at the Barrow Neurological Institute, which is in Phoenix, Arizona. His specialty in neurosurgical practice is devoted to patients with benign and malignant brain tumors, particularly those in high-risk areas. He is a renowned expert in brain mapping techniques to identify and preserve areas of motor, sensory, and language function during surgery. As one of the nation's highest volume neurosurgical oncologists, Dr. Sanai was elected to the American Academy of Neurological Surgeons in 2016. In 2018, he founded and now directs the Ivy Brain Tumor Center, a not-for-profit drug development program specializing in phase 0 trials and driven studies for brain tumors. So Dr. Sanai has authored more than 200 peer-reviewed publications and delivered over 100 national and international lectures in neuro-oncology. Ladies and gentlemen, I would like to introduce you to Dr. Nader Sanai now. Oh, there he is.
Thank you, Dylan.
Hi.
Hello, can you hear me okay?
Yes.
Okay, well, I'm honored to be part of this. I was just listening in. It's so inspiring to hear these stories and to see and meet, our community of patients and caregivers and providers as we're coming together to beat this disease. So, Dylan, you asked me to talk a little bit about some of our early phase trialing efforts, which I'm going to do. But I just want to reiterate, I think, some of the themes that I've heard so far, because it's so important for patients and caregivers to hear this, which is that the challenge with this disease in many ways is that it's different for every patient. And so what that means is what perhaps didn't work for some patient you met may work for you, and vice versa. And that's why, to echo the sentiment said, it's so important to cast a wide net when you're looking at your options. It's so important not to give up hope.
Yes.
Because even if something didn't turn out well for the patient before you, it doesn't mean that's the case for you. It's a really individualized disease to struggle with, but that means there's an opportunity here for each of you to have a future very different from what you might see or read about on the internet that sounds so scary. As Dylan mentioned, I'm a neurosurgeon and a brain tumor researcher. I'm at the Barrow Neurological Institute in Phoenix, Arizona, and we have a brain tumor research program here, probably one of the largest in the world, that focuses on drug development, called the Ivy Brain Tumor Center. These are my disclosures. I don't take any money from industry. I have no paid relationships with any specific therapies. This is part of our policy here at our program, which means that I'm agnostic to what may or may not work. I'm just looking for the data to support anything promising. I think everyone here is familiar with the tumor and how quickly it can recur. You can have an operation on one weekend, and then as you're waiting to get other treatments or getting them, the little cells of this tumor are spreading. And this is the exact problem. In our field, we often have a refrain that we say, gliomas are not a local disease. And what we mean by that is that this is not a tumor where an operation can cure it, as many of you know, because there are components of the tumor that you can't see. This is why even for patients that get aggressive therapy, like this patient of mine, the tumors can grow back, often do. And this is why the treatments have to be global. As all of you know, there are 4 general treatments that are proven to be effective. Surgery, the chemotherapy temozolomide, fractionated radiotherapy over 6 weeks, and Optune, which I think you're going to hear about. Outside of those 4, everything is experimental. It doesn't mean it can't work. It just means it's not proven to work. And there's a reason why we only have 4 things. The first is, this is a really complicated disease, way more complicated genetically than any other cancer. So this is what's called a karyotype. These are all the chromosomes, which are the little structures in your cells that contain your genetic material for a normal cell in a normal patient, in a patient without any disease. This is how it's supposed to look like. It's nice and neat, it's symmetrical, it's very predictable. There are 23 chromosomes that encode everything in your body. This is what the karyotype looks like of a glioblastoma.
Oh, Dr.
It's
Sanai,
yeah.
may I interrupt you? We are not seeing the slides as you're talking about them.
Oh,
We're still seeing the first slide.
interesting. Okay. Let me stop sharing and reshare
Okay.
and see. Do you see that?
Not yet.
Give it a second. Oh, okay.
Shall we try it again?
Yeah.
Oh, there we go. We see it.
Oh, you got it?
Oh.
Oh, I just unshared it. Okay, sorry. Let's
That's
do
okay.
it again. Do you see it now?
Not yet, but we will.
Okay. Okay. We'll just be patient.
Gotta love technology. Ah,
Okay, I'm back. You
we
guys still there?
we see you,
Okay.
but we don't see your slide deck, not even the cover photo or
Okay,
cover.
no problem. I can fix this.
Okay, cool.
One of the people suggested that bandwidth may be reached and maybe we should turn off our cameras.
Oh, okay.
I was thinking the same thing.
Let's turn off our cameras. Okay.
Sorry, guys.
We see it.
Do you see the chromosomes?
Yes, we do.
Yes,
Okay.
thank you.
Okay, so are we good?
Yes.
Okay. So first problem, you don't need to be a scientist to see that the thing on the right looks nothing like the thing on the left. This is a big problem for us. Unraveling this disease means we need to understand this. Second problem, as many of you know, Developing therapies for brain cancer is not a priority for the biotech and pharmaceutical industries, which is very understandable. These are for-profit industries that base their investments on the size of the market, and the brain cancer market is not very big. So it's actually very simple to predict where you're going to get new drugs, because it's directly proportional to the size of the market that the drugs will go to. And so it's not a surprise when we look at the last 5 or 6 years of cancer survival trends that brain cancer and other brain tumor type cancers really have had no significant change in their survivability, but something like melanoma or lung cancer, which are extremely large markets, have had really substantial survivability changes. So this is another factor that causes us to swim upstream. The third factor is that similarly, the federal government and the national efforts at brain cancer are comparatively small to other national efforts for other cancers. 25 years ago, we started to create these large consortia of centers, which are sort of groups of major universities and brain cancer centers working together to develop new drugs. And little by little, the amount of funding for each of these efforts went down, and the number of groups went down. And 10 years ago, there was only one group called the ABTC, and today there's no groups, with the ABTC losing its funding. Now, this doesn't necessarily mean we can't make progress, but it just speaks to the fact that, generally speaking, in our country and worldwide, it's all about political will. If you think about HIV/AIDS in the 1980s, it was completely unsurvivable and it was a death sentence. But there was enough political awareness and political will where resources shifted, priorities shifted, and today it is a very survivable disease because we developed 3 or 4 new classes of drugs that treat it very effectively. Now, the companies themselves that are in this space also have their own priorities. And so sometimes their priorities and maybe what's better for the greater good don't align. And the reason for that is because there's only a limited number of brain tumor patients. And so when we have clinical trials, there's a limited number of people that can enter those trials. The fewer there are, the harder it is to get an answer to a clinical trial. So when companies kind of follow bandwagon trends and open up a lot of trials, many centers have no choice but to open these trials as well, because that's where the funding is coming from. But in fact, some of those trials shouldn't be open. And some of those trials really are unpromising, but nevertheless will happen. You see that today with immunotherapy. Today in the United States, there are more slots for immunotherapy trial patients than there are patients available. So it gives you a sense of this extreme sort of bandwagon mentality that makes it difficult to have diversity of trials. And another thing that really works against us is unfortunately, is just the extreme commitment of the scientists and physicians in this community. As you've seen today, and as you've probably learned in your experience, these are very dedicated individuals. And sometimes that dedication just takes you too far, where it's difficult to look at a trial and say, you know what, this is not working, or it's not working well enough. We should move on. We should stop trying to fine tune this and really just reallocate our resources towards a totally different effort. But it's difficult for investigators and doctors and scientists to make that choice sometimes because they want it to work so badly. So this was an editorial by Lisa DeAngelis, who's the head of, or what at the time was the head of neuro-oncology at Sloan Kettering, and now she's the physician in chief, making this exact point, which is that, sometimes if a trial is not promising, that's what it is. It's not promising. It's not going to get better. we need to move on. So the Ivy Center, which is where I'm at, tries to take all of this stuff in mind when we develop clinical trials. So first of all, one of the distinctions that we make with ourselves is that we pay for all of our own clinical trials, which means that we don't take any industry funding, which means that we can make choices irrespective of where the funding is. Number two is we focus on drugs that are new to glioblastoma patients, meaning if there's a clinical trial at our center, we make sure that this is the first time glioblastoma patients are seeing this drug. If other centers are doing it, well, then that's good. They should do it, and we should focus on somewhere else to try to cover the most ground. And finally, all of our trials are what are called tissue-based trials, because one of the big challenges with clinical trials is it's hard to know if a drug is really working. As some of you know, the general way a clinical trial works is you're past those 4 standard options. You go to your doctor, they say, you know, I don't have any more proven options for you, but I'm going to make an educated guess that maybe this experimental therapy works for you. So we're going to take that educated guess on faith. You're going to take this experimental drug for a couple months, then we'll get a new MRI, and hopefully in a couple months, it looks better. And obviously the problem with that gamble is that a couple months is valuable time, and there's no guarantee it will work. And in fact, in many cases, there are problems with getting new drugs into the brain, for example, or having the effects that you want to have. So the way we do clinical trials is a little bit different, and you may have heard this term phase 0 clinical trial, but it basically begins with a genetic screen of the tumor, and then the patient is sort of, again, matched to the best educated guess we can make connecting the genetics to a new drug in our portfolio. That might be a single drug, it might be what's called a drug cocktail, which is a combination of drugs. It might be a drug and a device. But the point is that instead of just asking the patient to take the drug and then hoping for the best, we give it to the patient before surgery. And that way, when the operation happens, we can take the tumor out. This is only a few days after getting the drug, so there's no real side effects after a few days of any drug. We can test the tumor and say, did this drug get there? Did this drug hit its target? Is this drug having a detrimental effect on this patient's tumor? So this is very individualized. It doesn't matter what happened to the patient before or the patient after. It's about this specific patient's response to this specific new drug therapy. And so we get the answers to those questions in about a week, which means that by the time the patient is recovering from surgery and out of the hospital and all of that, we know, is this drug going to have a chance of working or not? If the answer is no, well, then the patient never goes on the drug. And we're back to where we started at the beginning, which is we need to find something else. But if the answer is yes, well, then now we can all have some confidence that it's worth this patient going through whatever they need to go through to take this drug for a couple months. Everybody has more confidence and everybody has more hope. And the way these clinical trials are designed, they're not really designed to detect some incremental benefit of a drug or a therapy. Because I think we can all be honest, that's not what we're looking for. We're not looking for a 10% improvement in survivability, a 5% improvement in survival. We're looking for home runs here. So we want to look for things that are clearly working. If it's not clearly working, we just move on in our program. You know, other people can try to fine tune whether that's going to work or not, but we don't think that that's a priority for the patients. The other thing that's really a priority for patients is managing side effects, because we all know that all of these treatments have their consequences. And so the classic way that clinical trials are done at most centers is you get a new drug and you just keep giving the drug at higher and higher doses until the patient gets sick. And when they get too sick, that's kind of the ceiling. And that's kind of the highest dose of the drug that patients get. So that's how clinical trials figure out how much drug to give a patient. They basically give patients one level below the highest possible level a patient could tolerate without getting so sick they can't take the drug anymore, which is really an old style of thinking, because in the 80s and 90s, most drugs were true chemotherapies. A true chemotherapy is just a toxin. Most chemotherapies are derivatives of things like mustard gas. So it's just designed to poison everything and hopefully poison the tumor more than it poisons your body. So when you have a drug like that, which is not a great drug to be on, it's true that the more drug you give, the more effect you have. But today's drugs are not true chemotherapies. Most drugs today are targeted inhibitors and other precision type drugs. And those drugs don't work by just giving more drug and having more effect. Those drugs have a sweet spot. And that sweet spot is often not the highest dose of the drug. In fact, for many drugs that are experimental, if you just maximize the dose based on what the patient can tolerate, that actually has the minimal effect on the patient. So in our trials, what we do is we don't look at the toxicity of the drug. We don't want to even see drug toxicity. We look at the drug effects, and we dose the drugs based on the drug effects because we have that evidence in front of us. We're not looking at a scan and trying to interpret what we're seeing and read the tea leaves. We have the patient's tumor, it's been exposed to the drug, we know exactly what the drug did and did not do, and so we can be very specific. And this lets us give patients lower doses of drugs with more effect. So I'll just walk you through three kind of different paradigms. We have many trials at our program, and obviously there are many trials worldwide, but three concepts of how this kind of strategy is working. One is the concept of moving away from single drug therapy, because everyone in our field feels pretty confident that a single drug is never going to be sufficient for this kind of tumor. So what our group or our center has done, and others have tried to do this as well, is we start off with single drug trials like we did several years ago, and we use those drug trials to figure out what is the resistance mechanism to this single drug. And then we move on to new trials like this one that's combining two completely novel drugs together to undermine that resistance mechanism. So a trial like this, it involves a drug called abemaciclib, which is a cell cycle inhibitor, and then it involves this drug with this acronym, which is typical of new drugs that are so new they don't even have a name. And this is a new drug from Eli Lilly. And so patients get these two drugs before surgery for about 6 days. And then on day 6, they go to the operating room and they have their tumor removed. And then we ask a simple question, which is, did both of these drugs get to the tumor? And did both of these drugs do something positive to the tumor? And if the answer to both is yes, then the patient goes on to both drugs. And this is the kind of data that we get from this kind of trial. Every column here is a different patient, and these are the concentrations of the two drugs in each patient. And the patients in red had enough drug get into their tumor where we know it can be effective, and the patients in white did not. So we only want to give experimental drugs to patients where we think those drugs have real smoking gun evidence that it's going to work. If not, this isn't about, playing roulette here, okay? We want to play chess, and that means knowing the data and not just hoping for the best. So this is the type of data we get from these patients showing that the biomarkers that we want to change are changing. And so these patients have a much higher chance of responding to the drug than the average patient. The second kind of category of trials that emerges from this is combining a drug and some other modality. So drug plus radiotherapy, for example. Radiation therapy, as much as we all don't want to have it, is actually the most effective single therapy for brain cancer today. More effective by itself than surgery, more effective by itself than Temodar or Optune, and it's very accessible to patients worldwide. So improving how effective radiotherapy is a very viable strategy. And tumor cells have lots of different ways to get around radiation damage. And so what we do is we target these little resistance mechanisms they have and combine it with radiation. And this is another important point, which is clinical trials are not just for when the tumor recurs. Clinical trials can be done at the time of initial diagnosis. And in fact, half of our patients with newly diagnosed tumors are on a clinical trial that combines experimental therapy with those 4 things that we know are proven to be effective. Why is that? Because as the tumor progresses longer and longer, it becomes more and more convoluted, and it's harder and harder to control. The best option, the best opportunity we have to control a tumor is when we first see it, when it's pure, unadulterated, relatively simple compared to what it's going to become. So this is a new in class drug called pamiparib, which is what's called a radiosensitizer. And this is a whole new generation of drugs that we're now deploying for the first time in glioma patients. And we can look and see the genetics of the tumors as they respond to these drugs. And this is why it's so important to take this one patient at a time, because different patients have different tumor genetics, even though they're all called glioblastoma. If you look at every row here, every row on the right is a different patient. None of them are the same. Everybody has their own version of a glioblastoma. You have to have individualized solutions. The final category is something called metabolic targeting. And in broad strokes, this is based on the concept that brain cancer cells still require metabolism. They still require the ability to generate energy for themselves like in normal cells. So you can exploit that. And so this is what's called a new in class or first in class, first in human clinical trial, meaning this is the first time any human has had this therapy called sonodynamic therapy. And this is a combination of a drug and a device. And so what happens is the patient comes in and gets a drug, and that drug has no effect by itself on the patient's tumor. It's not toxic, it has no side effects. Any one of us could take this drug and we would feel fine. But the drug is like an amino acid, and it gets metabolized by the tumor cells. And because tumor cells are abnormal, they metabolize it abnormally and they create a byproduct that they don't normally create. And that byproduct, coincidentally, can be activated by ultrasound energy. So the patient gets targeted ultrasound to the tumor. The ultrasound energy by itself, again, has no detrimental effects, but then the convergence of the two become lethal for the tumor cells and only the tumor cells. So here's a little video of the first patient worldwide that had this therapy not too long ago.
Today is our first patient for sonodynamic therapy clinical trial. This is the first in human study. So sonodynamic therapy is a combination of a drug and a device. It's non-invasive, doesn't require an operation. A patient with a malignant brain tumor gets this drug the morning of the procedure, and then there is a frame placed on the patient's head. It's fixed to the patient's skull. It's done with local anesthetic, so it's painless. The patient doesn't feel any discomfort. And then following that, the patient goes into the MRI scanner and gets attached to the sonodynamic therapy device.
So these types of trials are important as well, because obviously, number one, we want to be trying new things. We don't want to be recycling things that have been around for decades. And number two, because these are entirely new dimensions of treatment. This is not surgery, it's not radiation, it's not chemotherapy, it's not Optune. It's a whole nother category. We call it a new modality. So it's something you can layer on to everything else. And that's why it's important. This is how the targeting looks when you're targeting the tumor itself. And this also is a phase 0 trial, which means that we remove the entirety of the tumor like you see here. And then we look and say, did this patient benefit from this sonodynamic therapy or not? And we can say that definitively. There's no sort of hand wringing, trying to interpret a scan. We see the evidence or we don't in the tissue itself. And if the answer is yes, then they can go on to get more treatment if and when the tumor recurs. So again, it combines a drug that's given, followed by targeted ultrasound, and then the patient goes to the operating room and we measure all of these things related to that. So I know I didn't have a lot of time. I'm sorry if I went a little bit over. The Ivy Brain Tumor Center is a huge family of people that are all working on your exact problem. These are the faces of people that only spend 24/7 thinking and trying to unlock glioblastoma. We are completely focused on this singular mission and completely focused on getting patients and family members new therapies, because that's what really is going to move the needle, as you know. So with that, I will wrap this up and thank you for your time and attention.
Thank you, Dr. Sanai. That was truly amazing. And this patient population learned so much from you just now. Thank you for taking the time to explain. I also want to thank you in advance, actually, for your slides. Your slides were really easy to understand. So thank you very much. Really appreciate that. I want you to know that you have more time. We've adjusted our presentation schedule and you have more time. So please feel free. I don't want you to feel rushed, which also means I don't want any questions that you all might have. I don't want you to feel rushed. I want you to make sure you ask your questions. I have probably 2 in my chat box, so I'm going to access those and I'll ask you, Dr. Sanai, all right?
Sure, I'm ready.
Okay, it says, oh, good question. Mary Kay asked, Dr. Sanai, oh, where did it go? Does this information apply also to grade 2 astrocytoma? Very good question.
Right, so that's a great question. There are different grades of gliomas or astrocytomas. We grade them 1 through 4, as everyone knows. Grade 1 gliomas are typically curable with surgery. Grades 2, 3, and 4 typically require more than just a single round of treatment. Each of these grades have their own biologies. So the short answer is yes. There are clinical trials like the ones I described for grade 2 patients, grade 3, grade 4, and all of the subtypes within it. And that's why it's so important to make sure that as much is understood about your tumor as possible, especially the tumor genetics, because most clinical trials today rely on seeing those tumor genetics to match you to the right therapy.
I have a question, if it's okay to ask. There was a fairly recent change in the NCCN guidelines related to astrocytomas, right? Are you able to explain that a little better for all of us? All of us.
Sure. So astrocytomas in general, and we just call them gliomas, and there are different words for it, but it's all the same, have been kind of recategorized in recent years based on their genetics. And there are a couple new developments in that space. The first is that some patients where we previously thought they had a grade 2 glioma have the genetics of a grade 4. So this is called a molecular GBM, meaning on the imaging, it looks like a grade 2, but genetically it's actually a grade 4. And so those patients need to be treated accordingly. They can't be treated like a grade 2. And the other dimension is our management paradigm for grade 2s. If you're under 40 years of age and you have a grade 2 glioma and you have surgery and there's no sign of the tumor on the MRI after surgery, then the current management recommendation is not to do anything else, just to watch it with MRIs every 6 months. But if you are over 40 years of age with a grade 2 and the tumor has been completely resected, the recommendation is to treat it like a grade 4, meaning to do both temozolomide plus radiotherapy. Similarly, if you're under 40 with the grade 2, but the tumor was incompletely resected, meaning you can see some of it on the MRI afterwards, then either you need a reoperation to get the rest of it out, or if that's not possible, you should go on to get the same treatment as glioblastoma patients do, which is temozolomide plus radiotherapy. So in general, what we're recognizing is that even the tumors that we think are a little bit safer to have sometimes are not. And generally speaking, if there's an opportunity to be more aggressive, it seems to make sense for us to do that rather than to watch and wait.
Thank you. Very important. Very important. A question came in, another question that I would like to read to you, if I may. Thank you, Dr. Sanai. Do you do virtual out-of-state second opinions?
Yeah, of course. So about a third of our patients are out of state, out of country. We do second opinions, in state or out. An important thing for you to know is that when the pandemic happened, the federal government loosened the restrictions on out-of-state virtual visits. They basically said anyone can do it in any state and it's all billable through insurance. But now that the pandemic is starting to subside, the rules have gone back to how they were before, which is basically that you can't do out-of-state consultations in a billable way. So you can still talk to people, but it can't be an official clinic visit anymore. Our response to that has simply been, we don't bill. We'll do virtual consultations. We'll call them courtesy consults, so it doesn't get misconstrued as a billable clinical visit. And we just do it for free to just help patients sort through their options. I just spoke to a patient yesterday in New York. They had just had a surgery, at Cornell. They're doing well. I don't have anything to recommend to them that their local team can't do, but I think sometimes it can be useful just to hear it from a different source so you make sure that you're covering all your bases. So yeah, we do that routinely.
Thank you. Another question came in. You talked about this a little bit, but maybe you can expand on it just a little bit. It says, thank you for sharing. My partner is 1.5 years out from original diagnosis. When would be a good time to get in touch with you guys, now or after a recurrence?
Right, that's a great point. So I know that it's anxiety provoking to be constantly in treatment mode. There are windows, and for some patients, long windows where nothing's happening clinically, and that's good. And we want patients to get back to their lives. You can't constantly be in vigilante mode. You want to live your life. But that being said, it's never too soon to start establishing relationships with second opinions and other kind of, experts in the field. Because if you ever do get to the point where something has changed on the scan, you want people involved that already know your case and already are following along. So at the Ivy Center, we basically have this surveillance mode where patients that have had standard of care and are currently don't need anything and they're doing fine at other centers, other sites, other countries will connect with us. And we'll just make sure that whenever they get a scan, that we get a copy. And that way, anytime they get a scan, they hear from us as well. They also hear from their local team, but it's always like an additional check. And then if and when there's something new and we need to talk about a retreatment, it's a lot easier for us to give, informative sort of advice.
Thank you. I also want to remind everyone that we will be providing the information necessary to reach out to all of our presenters today after this event. So just so you know, you'll be able to reach out to Dr. Sanai and his team if you have more questions and you're interested in that second or third or fourth opinion or any of the treatment options he spoke about today. Another question came in, and this is a really good question. We hear this a lot. It asks, what is the best way to find out the genetics of my tumor?
So most centers that treat brain tumor patients either can do the genetic screening themselves. And so in that case, you just simply speak to your neuro-oncologist and say, can you please genetically screen my tumor? And for centers that don't have that capability, there are several national programs, national companies, Foundation Medicine, Caris Life Sciences, and there's a handful of others, and they're all pretty much the same. In my experience, one of them doesn't really provide any significantly better information than the other. Those things are billable to your insurance as long as the tissue is sent more than 2 weeks after your operation. So anyone can get it. Insurance companies cover it. And it's a great set of data to have. Now, the important thing to remember is most of the time when you get these genetic screens, it's not going to tell you, oh, you should do this or you should do that. The genetics are not that informative, but they can be helpful in guiding you to experimental therapies later or guiding your doctors. And that's why it's good to have it in hand.
Thank you. I have to ask you the last question, although we literally could spend hours because you're so informative and the patients and caregivers who are watching this are so engaged. They have a lot of questions, which is wonderful. Last question. Do you also perform these trials on patients with pacemaker dependent and abandoned pacemaker leads? I've been told that having an MRI is possible, but need to find a treatment center that will perform this.
Right. So obviously, sometimes patients have other medical issues outside of their tumor, and cardiac issues are not uncommon. And for some cardiac patients, they have pacemakers, and some of those pacemakers are MRI compatible. Some of them are not. Some of them can go in the MRI if you switch them off. So number one, it's important to know what category you're in. And the easiest way to figure that out is either to ask the office of the cardiologist that orchestrated the pacemaker, or to simply call the company itself, because the companies keep track of every pacemaker in every patient. Now, if you have a pacemaker that's not MRI compatible and you have a brain tumor, you need to first ask your cardiologist, do I absolutely need this pacemaker? Because sometimes after a period of time, you don't. And if the answer is no, then you should get it out, because MRIs are so helpful in tracking brain tumors and CT scans are much less helpful. However, if you're in the category where you need the pacemaker and you can only get CT scans, well, then everyone's got to do their best. And that's how we approach it at our program, and most centers do the same. You're not excluded from a clinical trial because you can't get an MRI. It's just that it's a lot harder for everyone to keep track of the tumor, but we'll still do our best.
Thank you. Okay, I promised that was the last question, but I am going to ask one more, and then we'll and then we'll move on. I do want to let everyone know that we have rescheduled further down in this program, Dr. Chautka, who will be speaking about gamma tile therapy and the new Rhodes clinical trial. So we'll be hearing from him a little bit later on in our program. The question that came in that I think is really important, and you did address this, maybe you could address this a little more. Do GBM patients need to be at an early stage of their GBM journey to qualify for these quote new in quote trials?
Yes. So every trial in general has its own set of criteria. I showed you some trials where it's just for newly diagnosed patients, and then I showed you other trials for recurrent patients. So depending on where you are in that journey, that will dictate what trials are options for you. But in my experience, almost always there is a trial option for any patient at any stage. We routinely have trial patients that have had 2, 3, 4 prior operations, and that's fine. I think that if you've had that many operations, it actually means you're doing pretty well because you've had these opportunities to get retreatment. So don't be discouraged if you feel like, or you've been told, oh, well, your tumor won't qualify for any trials. That's usually not the case. But, the answer is always individualized.
Thank you so much. I know everyone joining us today truly thanks you, Dr. Sanai, for your time and your education today is invaluable. So I just want to say again, thank you. And I appreciate your time and your expertise. And I also want to thank you again for joining EBCI's Medical Advisory Board. This is amazing. We're so excited. Thank you. And again, we will be sharing the information on how to reach back out to you and your team that we're allowed to share with everyone who's registered today. Okay.
Thank you, Dylan. Thank you,
Awesome.
everybody. Keep pushing ahead. I'm here for you guys. You need anything, you have my contact. Our whole team is ready. And, I wish you all the best, and we'll continue to push for the same fight.
Thank you. Thank you so much. Okay, you guys, I'm sure you were blown away with a lot of that information. It was exceptional. Now moving on, we would love to talk to today. We have the joy of meeting a GBM patient ambassador, as well as his GBM caregiver ambassador wife. Right now, I'd like to introduce you to Dennis and Yvonne. They are here. They're live with us on screen. And let's see. I see you. Hi. How are you? Oh, let's unmute you. Hold on. Oh. I just need you guys to unmute yourself, and maybe we can do that on our end.
I got it.
Okay, I hear you. All right.
And you can see us.
Yeah.
We can see
Wonderful
you.
program.
Dennis,
That was
I
a
need you
great
to sit a
program.
little, Dennis, I need you to squish in just a little closer to your lovely wife.
That's what I was going to do.
Ladies and gentlemen, I would like you to meet Dennis and Yvonne. They are, I'll stop talking because they have so much to share with you today about their GBM journey and how they are giving back to the brain tumor community and how they're helping all of us understand more about this disease and how to live with this disease, as well as to go forward and educate others and inspire others. You have the floor, Dennis and Yvonne.
We're going to let Yvonne go first.
Okay.
Hi, everyone. Thank you for this opportunity. Dennis and I have been married for 54 years. We are happily retired. I've retired twice. And we moved to be closer to our kids and grandkids after retiring, which was a very good thing to do. Part of our retirement is keeping busy, taking trips, and some of those trips were made to Stratford, Ontario, Canada, where we like to go see plays and musicals and just spend a few days there. It's a wonderful little town. On our one journey there, Dennis had been acting just a little bit off. It wasn't anything I could put my finger on, but I noticed something was off. After this many years, you notice. And every night after the plays, we would go to our car, but we couldn't find it. This is not a new thing for me. I don't find my car, but for Dennis, it was totally out of the ordinary and very concerning. But we managed to find it at some point each night, and then enjoyed our time there and came home. And the following week, he had a golf outing planned with some of his friends that he did annually, and was to go up north in Michigan for a few days of golf. And he left, and they were playing not too far from our area for their first game. But I noticed he had left his phone at home, so, which was another thing that would be very unusual for him. So I let one of the other fellows know that he had forgotten his phone. And so the plan was he was going to come after the game, and I was going to meet him halfway at our son-in-law's bowling alley. And it should have been just a very short trip, and I was waiting for him and waiting for him. And I was very concerned at this point because I thought something was happening, and I had no way to contact him because he didn't have his phone, actually. So when he did finally arrive, I said, "Where have you been?" And he said, "Well, I kind of lost my way," which was another thing that very unusual for him. Not usual for me, not unusual for me. I said, "I'm really worried about you." I said, "Maybe we should go get this checked out." He said, "Oh, I want to go do my golf. If anything happens, I can, like, one of the guys can do that." I said, "Oh, let's just go, just to be sure something's not going on." And he did say, "Fine, we'll do that." And so we did. And then we went to the ER. And we were registering, and one of the ER nurses happened to be walking by as we were registering, and she said, "How long has his smile been droopy like that?" And I looked at it and I said, "Well, he's always had kind of a crooked smile." I said, "But it is more pronounced." And she said, "You come with me." So right away, there we went.
Yeah.
So do you want to continue from here? Okay.
My name
So-
is Dennis,
so-
as you can see, and I'm a 75-year-old retired public school superintendent. And part of the reason we wanted to retire is so that we could travel and do things and spend more time with family, those types of things. My job kept me awfully busy, and sometimes we couldn't get out, do the things we wanted to do. So after the nurse recognized that something was going on, they put me in stroke protocol, and I saw a doctor right away. They did a CT scan, said, "Oh, you have a lesion, but we don't know what that lesion is, so we're going to send you for an MRI." And then they sent me for an MRI, and they came back and said, "You have a tumor." And the neurosurgeon and his physician assistant came in and talked to us and said, "You have what's called a glioblastoma multiforme, and it's stage 4, and we need to operate." But he said, "I'm going to be out of town until Tuesday, so I can't operate until Wednesday." This was on the Thursday before. He said, "It was an emergency. I'd have it done by one of my colleagues, but I'd prefer you wait for me." And we said, "Fine." So we had the surgery. After it was done, we were shocked anyway by the diagnosis that we were given, and you're a little scared. So I went through the surgery. It was about a 3.5, 4-hour surgery that they did, and the doctor said he removed 95% of the tumor. But as with glioblastoma or tumors in the brain, you can't take margins like you can on other parts of the body. So we knew there were still some pieces of the tumor there. So I went through the 6 weeks of radiation and chemotherapy. And when we got into the end of that, the radiation doctor that monitored that said, "I'd like you to speak to my colleague about another option for fighting this glioblastoma." And we said, "Great, we'll do that." So we made an appointment with a doctor, went in and sat down, and he talked about Optune. And he went through what Optune was, about the clinical trial, the advantages of it, and how it helped prolong your life a little bit. And he talked about the potential side effects and all of that. And I've always been one that's been kind of a fighter and will do what's necessary to get the job done. So Yvonne and I looked at each other and I said, let's do the Optune. So at that point, we decided to do Optune. And about a month later, the representative from NovaCure came, showed us what we had to do to apply the arrays, which you can see I'm wearing right now, and taught Yvonne how to do that. And the only downside was I used to have a full head of hair, a very thick full head of hair. And I had two brothers that were bald, and I used to pick on them. But now I'm balder than they are, so they can get back at me.
Dennis,
yes.
Dennis, how long have you been wearing the Optune device?
Over 2 years.
And how many hours a day do you wear it?
I wear it most of the day. I will take it off. I'll give you examples. I'll take it when I go golfing. I don't carry the machine with me. I may have the arrays on, but I tuck the cord in my pocket because I don't want to carry the machine around. That would just be hard to do. So, I may have the arrays off or not connected for maybe 4 hours, whatever it takes to play a round of golf, and sometimes sit down and have lunch and have a beer with the guys. I will take it off. We change the arrays every couple of days because I do experience some skin irritation, and the doctor did prescribe some cream for that. But we'll change them every couple of days, and I'll leave them off 3-4 hours. Otherwise, I have it on all the time, and I sleep with it, and I've gotten used to it. And,
you sleep with it.
oh yes.
Okay.
Oh, yeah.
So when I met you guys, we talked a little bit about, besides golf,
Right.
what, which I think is really important to talk about. What can you not, in OT, not do with this type of treatment?
Well, the only disadvantage I have is we put a pool in the backyard for the grandkids. So it's not a day to change the arrays. I can't go swimming with them. But if it's a day I have the arrays off, I still get in the water and play around with them. And, they jump all over me, do that kind of thing. So typical grandkid thing. So that's the only thing I can't really do is go in the water if I have the arrays on. I try to be careful when I go out in the sun, because if it gets too hot, it will alarm. And then I know I need to get in the shade and let everything cool down. So, I've gotten used to all that. And over time, you get used to those different things that you need to do. My MRIs recently and for quite a while have all been very stable, very similar. And at one point, the doctor looked at one from 6 months previous and looked at the one I just had, and he said, these are identical. And so that was a good thought.
Congratulations. Congratulations.
When I found out I had this, obviously it was scary and not knowing what was going to happen. And